Can you guys hear me?
Yes.
Yes.
Can you hear
Okay.
us?
Yes.
Okay, good. Just waiting for Facebook. Good afternoon or good morning for some of you. We're back again with our ANAwareness Week 2021 webinar series. Welcome. I hope you've had a chance to learn from our previous presentations, but if this is your first, I'm so glad you could join us. As always, our thanks to the team at Mayo Clinic for spending a great deal of time with us this week and sharing information and answering questions. It's been really terrific. Today's presentation features Dr. Michael Link and Dr. Colin Driscoll, both of whom I've had the pleasure of working with in earlier presentations. Dr. Link is a neurosurgeon and Dr. Driscoll is an otolaryngologist, both in Rochester, Minnesota. And joining them today is registered nurse Marina Kastner. Today's discussion will focus on how to prepare for vestibular schwannoma surgery and what to expect. Welcome to all of you and thank you for being here. I'll have you tell us a little bit more about yourselves and your work with AN patients in just a minute. I'd like to first mention a few things about how our presentation will run today. All of our attendees are muted, so you're only able to listen. If you have questions throughout the presentation, you can ask them in the questions box if you're in the webinar, and that's located in your toolbar. Or if you're watching on Facebook, you can just post your questions in the comment section. We're watching that as well. There should be captions at the bottom of your screen. If you don't see them, you can click the captions button in your toolbar. If you're in the webinar, if you're on Facebook, you may have to activate them in your settings. We are recording this presentation and we'll house it on the ANAwareness Week landing page on our website in the presentation section. We'll also keep it on our Facebook page and it will be in our video library. There's lots of ways to get involved in ANAwareness Week this week. Visit our website at www.anausa.org and click the slider on the homepage to find everything you need to know. Following this presentation later today, we have two more scheduled for today. One was actually supposed to be this morning at 11 a.m. Eastern, and I just want to make my apologies for having to reschedule that one. We had a scheduling conflict, so that one is now going to begin at 3:45 Eastern time, and that's on eye issues associated with vestibular schwannoma. And if you have the link that you had before will work to get you into that webinar. And then at 5 p.m. Eastern, we will welcome Dr. Price, who will talk about facial reanimation surgery. So lots to talk about today, but first we're going to talk about surgery. Dr. Link and Dr. Driscoll, and thank you so much for being here today. And if you want to go ahead and introduce yourselves and get started, we can go ahead.
Well, thank you very much, Melissa. It's our pleasure to join you once again this week. It's been really fun. I really appreciate what the ANA does and what you do to support patients as they make their journey through acoustic neuroma management. We get that it's complicated and scary. It's been a major interest of myself and Dr. Link and Marina, frankly, to participate in the care of patients that have acoustic neuromas, and it's something we think about day in, day out. And so happy to share our thoughts about surgery and the journey through surgery today.
Thank you.
As mentioned, my name is Michael Link. I'm one of the neurosurgeons here, and Dr. Driscoll and I have actually been working together now more than 22 years with, as Dr. Driscoll mentioned, a primary interest in acoustic neuroma management. And admittedly, a lot of the hard work is actually done by Marina, who's our nurse associate, who, while we're in the operating room operating, she's talking to patients and helping them through the journey. So we're just delighted to have her join us today. Mostly to make sure we answer answer the questions correctly. Altogether now, Dr. Driscoll and I have operated more than 850 acoustic neuromas over our careers so far. And we're happy to say that that's getting busier and busier as we progress through. And we thought a good way to start out would be to kind of just talk about, rather than showing a bunch of slides and data that I think everybody's seen over time, we thought we'd talk about just how we perceive the process is and what happens to patients as they meet us and then go through surgery. If you're not fully aware of it, Rochester, Minnesota is pretty much in the middle of nowhere. And so often patients come from some distance and meet with us. How it works is we actually operate every other working day. So for instance, this week we'd operate Monday, Wednesday, Friday, next week, Tuesday, Thursday. And the original idea of that is patients would come one day and have surgery the next day. But the opposite days we're in clinic seeing patients. But for acoustic neuroma, that rarely happens. Of course, people need time to process the information wisely. I think people often get second opinions. But the first visit is usually just a long consultation about symptoms and options and going over the imaging and the hearing and so on. And then when patients decide they want to have surgery, then we typically meet with them the day before surgery, once again, to make sure all their questions are answered. Certainly, everything in our lives has changed from about 14 months ago when COVID became the main topic of medical discussion. How it works now is we do test every patient that we wheel into the operating room the day before surgery. They get a nasal swab and a test for COVID. They meet one way or the other with the anesthesia team who talk to them about what the anesthetic process is going to be and make sure that they agree the patient is fit for surgery, that there isn't some underlying cardiac or lung issue that we didn't pick up in our initial discussion. And then we ask patients to actually wash their hair with a special surgical shampoo the night before and the morning of surgery, and then show up at our hospital around 6 a.m. in the morning. They get checked in. They go down to the preoperative recovery area where they meet with the actual anesthesia team that's going to be doing their anesthetic that day, and then typically wheeled into the operating room around 7:45, and then off to sleep under general anesthesia. We've never ever had a patient say that they woke up during anesthesia or they remember any part of the operation after they went to sleep. After people are completely anesthetized, then the anesthesia team puts in an arterial line to measure the blood pressure beat to beat. Urinary catheters put in, and then our monitoring technicians put in little needles in the facial muscles and some other monitoring techniques so we can monitor the regional nerves. And then we do the operation, and that can take as short as 4 hours and as long as 12 or 16 hours, depending on the size of the tumor. Most of that surgery is done under an operating microscope. Occasionally, we do use endoscopes to look around corners or to look out to the end of the internal auditory canal. We don't really use lasers or anything like that. The instruments are very small and delicate, let's say, and it's really a team effort. So Dr. Driscoll and I spend a lot of time sitting under the microscope as a team, with one of us working and the other one kind of offering advice, let's say, and back and forth. After surgery, once the operation's all done and the incision's all closed up, then patients are woken up right in the operating room. And as they're waking up from anesthesia, we ask them to wiggle their fingers and toes. And especially we ask them to close their eyes tight, smile, so we can assess how the facial nerve is working right away. Most patients have no recollection of this. They're still anesthetized enough that they don't quite remember that. Then we wheel them to the recovery room, where they spend about an hour or two really waking up from anesthesia under careful nurse monitoring. Usually at that time, we can get a fairly good idea what the facial nerve function is. It sometimes is hard to tell if people can still hear out of that ear just because there's a tight head dressing on. And then patients go up to the intensive care unit, usually for only one night. And that's become quite routine at our institution, that after brain surgery, whether it's a small tumor or a large tumor or a short operation or long operation, we monitor people one night in the intensive care unit. During that time, patients are hooked up to a lot of tubes and wires in terms of continuing to monitor the blood pressure beat to beat and monitoring the EKG with little electrodes on the chest. And we usually keep the urinary catheter in because people don't feel like getting up and using the bathroom. It's a hard place to get a lot of rest. In general, I think hospitals are a terrible place to get any rest, but the intensive care unit is really a hard place to get any rest. The nurses come in every hour or two to check on the patient to make sure that there's nothing untoward happening. And then typically we see patients the next morning on rounds. And if everything goes as planned, they can go to a regular hospital room. Most patients are really dizzy the first 24 hours after surgery and don't want to get up out of bed. But usually that second day, people start to feel better and can mobilize, and we can get the dressing off the head and get the urinary catheter out and most of the IVs and those kinds of things, and people can get up and start moving around. We typically get our physical therapists to see patients to help them with vestibular exercises so they can kind of relearn their balance, so to speak. Most people are in the hospital a total of 4 days. If you count the day of surgery as day one. And then people are able to go home and be with their family. We do usually ask that they not go home alone. So for the first couple of weeks, I think it's helpful to have somebody around. They don't have to be with the patient every second of the day, but I think it's quite helpful. People are on pain medicine, so they might not remember, did I take that pill or not take that pill, or so on and so forth. And we don't want people to do anything exertional. We don't want them to lift or bend a lot. So it's helpful to have somebody get your groceries or carry your laundry up and down the stairs and those kinds of things. We encourage patients to do a lot of walking. That's actually great vestibular rehab, just walking, but nothing where they're going to break out in a sweat or get their heart rate up high. So, no running on the treadmill or digging the garden or shoveling snow or changing a tire on a car, things like that. And I think we prefer those restrictions, for 2 to 3 months, where we ask people to kind of take it easy in terms of exertional type things. People often ask, when can I go back to work, for instance? Colin, do you have thoughts on that?
Yeah, I think our first question back to them is, what do you do for work? Because that's certainly going to impact time to return. If you do a lot of heavy lifting, straining things, we'll probably suggest it's a little bit later of a return. If you can work part-time, and certainly if you can work like lots of people are now remotely, and you have flexibility, then you can start to work your way back to that sooner. I think one of the things that's really remarkable is the recovery for people is highly variable. And so people chart their own pathway, and we have no idea how to predict what one person's journey through that recovery is going to be like. I think, and most people are ready to go back to the lighter duty work things at 6 weeks. And especially if you have the flexibility, but plan on 6 weeks of not working. Give yourself a chance to recover. These are big life steps. The rest of life will be there when you get back. Now, if you're completely bored and you want to do email, then start doing your emails. But plan on 6 weeks. You can always go back sooner. And plan on 3 months if you do a lot of heavy lifting, straining things. We do alter the recovery recommendations a little bit depending on the surgical approach and maybe some of the how things have gone post-operatively. But that would be 6 weeks, 3 months are 2 time frames that I think about.
Marina, we actually saw a patient just last week who owns his own construction company, so he doesn't actually do the hard work, but he's got a pretty high level job. And interestingly, he told us somebody told him he could go back to work at 3 weeks. You know, you talk to a lot of patients. What's your sense of it? What do you think is good advice for people?
So I think 3 weeks might be pushing it some, to be honest, with hearing from patients. But I often tell patients, 6 weeks, you might be able to go back to work if you don't have heavy working. But really, to plan for 3 months off work is kind of reasonable to do, and to have a plan in place. Often we would, if they plan for that and can go back sooner, then we certainly support that, is often what I tell patients. And it's a bonus psychologically, I think, too, if they get to go back sooner versus, 4 weeks comes and, I was planning to go back to work in 4 weeks. Now I don't feel so good. How's this going to work? And just added stress that they don't really need at recovery is how I approach it.
Yeah, I'll add that Marina does a mountain of paperwork, I'll say every week, regarding all the short-term disability and long-term disability. And it's absolutely true. If we fill out the paperwork that you should be off work for 3 months, it's easy to change it to say, well, now you can go back at 4 weeks or 6 weeks or 8 weeks. But if we say you can go back to work at 4 weeks, sometimes, depending on the employer, it can put their employment in jeopardy if then they come back and say, well, I need another month or something like that. So we do think it's better to kind of prepare for a longer time off work and have the bonus of being able to go back sooner than the other way around.
Yeah, you probably win bonus points from your employer if you show up earlier than expected, and it's problematic when you change their plans. There was a question about when people travel to Rochester for surgery, how long on average do you have them stay before returning home? And that's a question we definitely hear a lot. And our general strategy is get people through surgery. When you leave the hospital, stay in town a couple of more days. And that allows you to get your feet under you outside of the hospital environment. Start to face some of the little hurdles of day-to-day life while you're still here, and then travel home after that. And another question that always comes up about, well, can I fly home? And if you live a long ways away, I would fly home. There's no real risk with flying. And it's far better to take a shorter flight than to spend 14 or 18 hours in a car driving home and putting yourself at risk of blood clots. So flying is okay with us.
Yeah, we usually tell patients, you're going to be in Rochester, Minnesota, basically a week, 7 days. If you count the day before surgery, 4 days in the hospital, a couple more. I think it is really important those couple of days after you leave the hospital, because sometimes people way underestimate how much is taken care of while you're in the hospital. I mean, some patients, just get used to the nurse wheeling the cart up to their bed and have all their meals still sitting in bed. And all of a sudden,
that sounds good.
Yeah, I know. All of a sudden you get to the hotel and you've got to put on real clothes and walk out to go get something to eat. Yeah.
That was actually going to be one of my questions for Marina, is what kind of things do you look for? Are you in the ICU, or are you, where are you in that whole process?
So I see patients with Dr. Link and Dr. Driscoll before surgery in the clinic setting, and do a lot of pre-op teaching. And then I also will do rounds in the hospital with Dr. Link in the morning after surgery. And I usually try to talk to everybody before they leave the hospital, make sure their questions are all answered and they know their kind of tailor their post-operative instructions to how their post-operative stay has come about and the outcomes of surgery. And then I also see patients in the clinic for follow-up and do phone calls afterwards. So I don't
that's
really
great.
work in the ICU, but I see
Yep.
them in the ICU.
Okay. So what are the nurses and the doctors even looking for, and you went to determine whether or not when they're ready to move out of the ICU? And I know it's generally within 24 hours, but are there certain, markers that they have to reach before they can move into a regular room?
Well, the main thing is we just want to make sure that there's nothing concerning from a neurologic standpoint, that we don't have to worry about spinal fluid buildup in the head or bleeding in the head or stroke or anything like that. So we're just looking at overall neurologic function, and then hemodynamics, make sure the patient didn't have any chest pain or anything after surgery that would warrant concern about a heart condition or something like that.
Okay. And then also you mentioned having a physical therapist potentially come and see patients before they're released for the hospital. So what kinds of things are patients dealing with where the physical therapist might help them?
If mostly it's the postoperative vertigo and instability from loss of any remaining balance function. Some people, they've already lost all the balance function. They've already compensated well. Although it's uncommon, you occasionally see people up in the chair the evening of surgery in the intensive care unit eating food. And so if you've already gone through that, it makes your surgery a lot easier in a way. But most people have some remaining function and have some degree of vertigo postoperatively. And that's going to last essentially 1 to 3 days. And if you have a small tumor, you have a lot of function and you lose that, it's closer to the 3 days. And so the physical therapist will assess your current balance function. They'll assess your home situation, and do you have to navigate steps or not? They'll have people walk the steps in the hospital and determine safety, determine what gait aids might be appropriate, whether that's, maybe you need a walker for a few days or a few weeks at home to keep you safe. Falls are a big problem in healthcare. And certainly in the postoperative period, when you've taken away balance function, had a big operation, you're at increased risk of falls. You're taking narcotic medicines, you're tired, you're fatigued, puts you at increased risk. And so there's a lot of effort placed in keeping people safe as you go home. I want you to be mobile and safe.
Yeah. What do you have? I recall one time hearing a presentation where people talked about tips and things for patients as they go home, because they do have to, you want them to be safe. And somebody said something about, if I recall correctly, like hard-soled shoes or something, just not real soft shoes to kind of help your balance. Is there anything like that that you tell patients as they're leaving to that might help them navigate being at home?
Yeah, from a fall prevention standpoint, there's a number of things you can do. One is avoid the stairs if you can. So if there's a main floor bedroom you can move down to or something like that, that's helpful. There's loose rugs, things on the floor, catch your feet. Having a night light on or a light source, depending on how your overall balance is. Turns out glasses with progressives or bifocals are problematic because they don't let you see your feet. So either not wearing glasses, if that's a possibility, or having distance glasses only without the bifocals can be helpful.
Somebody asked about that in one of our earlier presentations.
Yeah, that's especially appropriate when you're out walking. And you can't see curbs very well without looking down. Well, looking down takes away your vision of the horizon, and it puts you at increased risk of falling. And footwear, there's sensible shoes and there's not sensible shoes. Wear sensible shoes. Yeah, it's easier.
Okay. Marina, we did have a question on Facebook about with the variety of potential side effects and the length of time it takes for recovery. If we're talking about 3 months, how do you help patients sort of coordinate their post-care and the team of people that will help them do that? Or do you do that? Whether that's, people, I'm sure they have people on their end, but even follow-up care and that kind of stuff, how it's kind of long-term. How do you help them with that?
So it kind of depends on what they're having some troubles with or what their symptoms are afterwards.
Mhm.
But often if they're having troubles with the balance, I encourage them to, walk a lot, and maybe it's to have vestibular therapy at home. And help them work with their family physicians to get that arranged. Typically, we see patients back in 3 months and they have our phone numbers. Often patients will call me or send a message through the online portal, which is like a secured email system that we have, that then I can help them navigate their symptoms. Is it, normal? Is there other things to do? If it's headaches, there's different things that we can tell them, maybe alternating medications. Maybe it's talking with Dr. Lincoln Driscoll about setting up to see a headache neurologist when they come back. It can be a little bit variable, but those are some things I can think of that are common things.
And also frequently Marina arranges, we leave the staples or sutures in for 2 weeks. She'll arrange with the primary care doc locally to get those taken out at 2 weeks.
I don't know if it was Dr. Driscoll or Dr. Link mentioned that sometimes you adjust the recovery plan according to which surgical technique was used. So how do the recovery plans differ depending on the surgical technique?
Yeah, maybe 2 factors in that. One is our concern for potential cerebral spinal fluid leak. Some people are at higher risk than others, especially, so there's certain factors that put people at higher risk. And so we may adhere to lower weight restrictions for longer. In general, more likely to have people who've had translabyrinthine surgery return to more normal activity by 6 weeks. I think they don't have as much trouble with headache at that point, whereas some patients who have had a retrosigmoid approach will still have more trouble with headache if they increase their activity a lot. Now, I say that hesitantly because that applies to some people, but not all people.
Right.
And so.
Yeah. That's great to
I
keep
think,
in mind.
Overall, the recovery, so in our world, when you go to the medical meetings where we all get together and debate these things, for a long time, there was this big debate about, is retrosigmoid or translabyrinthine or middle fossa the best approach to take out an acoustic neuroma? And certainly when we do all 3 and when we've looked at our results, the results are basically the same. I think the basic recovery is the same. So oftentimes patients will come to us and say, well, this doctor said I should have the translabyrinthine approach because that's better for my facial nerve. Or I should not have this approach because I'm more likely to get a spinal fluid leak. And I can say, after having done almost 900 of these operations through all different approaches, the results have not really anything to do with the approach as it has to do with the size of the tumor and what the preoperative condition is and those kinds of things. So sometimes we do see people get very tied up in trying to figure out what operation should I have done. And I'm always fond of saying, you should have whatever operation the team who's going to operate on you thinks is the best way that they can provide you with the best result. The patient doesn't have to figure that out.
Yeah.
We've spent years and years thinking about that.
Yeah. That's great advice. I think this is a great question, and it's something we've talked a lot about since we're the Acoustic Neuroma Association, but she's asking what the correct term for the tumor is. Is it vestibular Neuroma or acoustic neuroma?
I
Mhm.
hate to tell you what the correct term is
I
when we're
know what
on
the
an
correct
Acoustic
term
Neuroma
is.
Association event, but the
I
correct
know.
term is vestibular schwannoma. And the reason is acoustic means auditory. It's not a hearing nerve tumor, and it's actually a schwannoma, not a neuroma,
Right.
pathologically.
Right.
But we use the terms interchangeably, and but there's been a pretty dramatic change actually in the use of vestibular schwannoma. I would say maybe over the last 5 years, and I think it's becoming more and more referred to more and more that way.
Yeah. Well, what is the difference between a schwannoma and a neuroma and the acoustic? Now, is the acoustic nerve part of the 8th cranial nerve, which is the vestibular cochlear nerve?
Yeah, so the 8th cranial
name
nerve,
or
8th cranial
different
nerve
names?
has 3 parts. You can say it has the hearing part, so
Mhm.
the auditory nerve, and then there's 2 balance nerves,
Gotcha.
if you follow them out far enough. So there's a vestibular part, a balance part, and an auditory part. And the schwannomas come from the cells, the insulating cells around the outside of a nerve.
Mhm.
And a neuroma comes from the actual nerves themselves. It's maybe
Okay.
the easy way to think about it.
Okay. We have lots of patients come back and say that they have pain at the incision site several years out, like many years out from having surgery. So why would that be, and how can it be managed?
That is certainly a vexing problem. That I don't think there's a one size fits all or an easy answer to that question. And I think the first thing we think about is it a problem with pain in the incision, or is it a headache problem? Because the treatments are 2 very different avenues. So if somebody says, it hurts here in my incision, usually one of the first things we do is send the patient over to the pain clinic, and they get an injection to anesthetize that area. And if that solves the problem, which is transient because it's just a local anesthetic and a steroid usually, then we can at least be confident that we're barking up the right tree. And then sometimes they can have a more permanent treatment of that area to numb it up, so to speak, to make the pain go away. For a while, many, many years ago, it became fashionable to take patients back to the operating room, reopen the incision, assuming that it was a scar problem, that one of the cutaneous nerves, which gives sensation to the back of the head, was trapped in scar. And so people would go in, basically cut out the old scar and then sew the wound back together. And I always wondered to myself, doesn't it just make scar again? How exactly is that helping? So admittedly, we never sort of jumped on that bandwagon, but I think it fell out of favor, basically. But some people, I think, do get nerve irritation. And if these pain clinic procedures don't work, sometimes medications that are used to treat chronic pain work. Gabapentin is a very popular one, or pregabalin, which is kind of a cousin of gabapentin, people use. Those medications are typically well tolerated, meaning they don't have much side effect. If people have headache, if they come back and say, every morning I wake up with a headache, or my headache develops, then I think that's a different problem. We don't really understand the etiology to. It certainly reminds me to at least mention that we kind of think about myths in all this. And one of the myths that we often hear is people will say, well, I was told if I had a retrosigmoid craniotomy, I'm doomed to lifelong headache. And in fact, we looked at it very closely here, along with our colleagues in Bergen, Norway. And it turns out that the main risk factor for long-term headache is having a bad headache history before you got the diagnosis of your tumor. So if you have a bad headache history, you have surgery for an acoustic neuroma, there's a much higher chance you're going to suffer with headache afterwards. but surgical approach did not contribute to long-term headache. Sometimes we can manage the headache in terms of, there's a variety again of non-opioid type medications that people can take to help headache. We can try and tease out a little bit more, is this a chronic migraine problem? There's a very, I'll say, common problem called medication overuse headache. So if any of us on the call today started taking, let's say, Tylenol twice a day, every day for a month, and then stopped taking it, a certain percentage of us would develop headache. So it's not like addiction, but it's a separate kind of an issue. So sometimes if we can just get people to stop taking ibuprofen or Tylenol or something for a week, it'll kind of break the cycle. That can be a miserable week, as you can imagine, because people are used to taking something for their headache.
Yeah.
And then there's a variety of other, like I say, medications. And if we can't figure it out or don't seem to be making progress, we have a group of neurologists that we work with that can get into more depth and try and help patients.
I would just add too that sometimes patients have found acupuncture has helped when they get far enough out from surgery, or like neck massage or massage that area. So they do find, some patients have found that to be helpful as well.
Okay. We actually had a patient ask about using guided meditation for successful surgery before treatment. And is that something that you've had experience with any patients, and has it been effective for some people?
I don't have any experience with it, but I don't doubt it would be helpful. Yeah.
Okay. Marina, how do you advise patients who leave the hospital with facial issues, and what kind of follow-up care do they need? As far as, figuring out, does it just sort of come back? Do you leave it go? And then, or do you look for a specialist to help treat that?
Well, a lot of my teaching is guided depending on what Dr. Link and Dr. Driscoll found in the operating room, and what their, what their thoughts are about their facial nerve. So sometimes patients will have some facial nerve weakness, and Dr. Link and Dr. Driscoll will say, well, it'll get better. And it just will take a number of months to get better. So often I really stress the importance of taking care of their eye to make sure that it is moist. It kind of depends on how far away they are from us. Sometimes we see them back in 6 weeks and see how they're doing with their eye care, because that is really the main thing to be, conscious about. And also, if Dr. Link and Dr. Driscoll feel that, we need to do some facial reanimation sooner after surgery, then we would move forward with getting that arranged. That's pretty rare that even happens. And sometimes patients wake up and have normal facial weakness, and then they can have a delayed facial weakness after surgery about the time their staples come out. So I usually talk to all of our patients about that. So that has not been permanent facial weakness, so it gets better, but we ask them to call us, and I just kind of go through the eye care with them again, and really just encourage them that it takes months, not a week most of the time, to get better, not to be too discouraged.
Yeah. Thank you for sharing that, because that is something that that we've had questions about. If people wake up and their facial nerve is fine immediately, but then there is sometimes that delayed weakness that then is frustrating. So it's great that you address that with them and help them sort of manage expectations and how to deal with that.
Plus, often, patients that have facial weakness after surgery see themselves every day in the mirror. So when they see other family members that say, gee, I think your face is getting better, they should believe them, because it's 90% of the time it's true. And patients just don't notice it because can happen so slowly, the recovery.
Sure.
I do think it is important for patients to understand that if you do develop that delayed facial weakness, 7 days, 10 days, 14 days afterwards, that you call your team right away, because that's most likely related to a viral reactivation. So a virus in the nerve, similar to what causes Bell's palsy, which is a facial weakness. And so we treat that. We treat that with steroids, and we treat it with antiviral medication. So and especially the antivirals are much more effective if they're given really early on, within the first couple of days, frankly.
Okay. Interesting. We have a question on Facebook about an intracochlear schwannoma. Is that the same or similar to an acoustic neuroma?
Yep. Yeah, it's just in a little different location.
Okay. And this I thought is a good question as well on the webinar. How large of an area of the head is shaved before surgery, and does that depend on the kind that you get?
Yeah.
Yeah.
So for 22 years, Dr. Driscoll has been telling me I cut too much hair. For the translab approach, we don't cut much hair, mainly because Dr. Driscoll does that haircut. And this incision is closer to the back of the ear. For the retrosigmoid, we do cut, some hair behind the ear. And then for the middle fossa approach, we usually cut kind of a strip above the ear. If you have, real short hair, it would be visible. But for instance, for you, Melissa, nobody would be able to tell even right after surgery because your hair is long and would cover up that.
So you would just shave like the under part of it and then.
Yeah,
okay.
Right. Yeah.
Interesting. Okay. There's a question about having a history of dizziness. You mentioned having a history of headaches can potentially, lead to headaches post-surgery. Is that the case with dizziness as well?
Yeah, I think that's safe to say. If you're predisposed to poor balance preoperatively, and now we add a potential another insult to your balance system, you can expect it to add on to your pre-existing state. And one question we get asked is, what can I do to get ready for surgery? And these surgeries are rarely urgent. There's somebody asking a question about a 5-centimeter tumor, so it doesn't apply to this person or that particular person, but you can wait. And the better shape you are in going into surgery, the easier it's going to be to get through that. So if it turns out it's been a COVID year, you don't exercise anymore, well, get back to exercising, get your balance tuned up, and then have surgery. It'll make it easier for you.
Okay.
That's a really important question that people often ask is, how can I prepare for surgery? And there isn't any particular special diet or so on. I think the main things to think about is, you do want to be kind of in your best health. So if you smoke, you should really think about quitting smoking before you undergo an anesthetic. We don't want people to use aspirin or aspirin-related type drugs or any other blood thinners prior to surgery. So we want people to stop those about 10 days before surgery. And, just eat a well-balanced diet and get plenty of rest. And then there's sort of no other kind of special thing people need to do.
Okay. Well, let's address this patient that asked about the larger tumor sort of in a general sense. Is there a better chance with the larger tumor of losing hearing, of facial weakness or paralysis, that sort of thing? Is that generally the case? Yeah,
it's safe to say that hearing, the ability to save hearing and the ability to save normal facial nerve function directly correlates with tumor size. Once the tumor gets more than 1 centimeter, say inside the head, so
Mhm.
not counting the part in the inner ear canal,
Mhm.
the chance of being able to save hearing really goes down, especially if you already have some pre-existing hearing loss.
Mhm.
The facial nerve function, it varies a lot more, and it's a more nuanced answer. So if Dr. Link and I are asked to take out 100 tumors that are all 3 centimeters in size, we're going to have a certain percentage of people that are going to have some permanent facial weakness that's more than mild.
Mhm.
But the reality is, in today's world, we approach this differently. We take out the vast majority of the tumor, and we'll go in with the idea of taking it all out. If we can get it all out and if people can have normal facial nerve function, that's the goal. But if the tumor becomes very stuck to the nerve becomes very splayed out over the tumor surface, where we feel like if we keep working at this, there's a higher risk of permanent weakness of the face, we'll leave some tumor on the nerve. And that is a very small amount of tumor. Sometimes the really small amounts of tumor never grow, and we never need to treat them. We've taken away their blood supply, or presumably, and we just watch the remnant on MRI. If it's a larger amount of tumor, then usually we're treating that with radiation to control that, because now it's a small volume of tumor, whereas that 3 centimeter tumor to begin with, it's not very safe to treat a big volume of tumor like that with radiation. So the facial nerve outcomes are directly related to tumor size, but we modify the surgeries to achieve what people want, which is usually normal facial nerve function.
Right. Okay.
Yeah, so when the person asked, what's my chance of having facial weakness with a 5 centimeter tumor, it comes down to, well, if your main goal is you want to be cured, you want us to take out every last tumor cell, it's high. It's a high risk of facial weakness, because we know the facial nerve will be very thinned out. It's always adherent to the tumor. That's just the way this biology is. But if it's, well, we can leave a little tumor, then, we can get that risk down to 10% or less, let's say.
Okay. We have a couple of logistical questions, after surgery. One is, how long generally do you advise people not to shower? How long are they walking with a walker? And how long before people can drive generally? I know it likely differs from patient to patient, but.
Marina, do you want to take those?
Sure. So typically, patients can drive a couple weeks after surgery. Then they have to be off their narcotic pain medications and feel safe to drive, be able to, turn your head quickly in that. But usually 2 to 3 weeks off not driving. And as far as a walker, I would say everybody's different, but usually patients don't need a walker very long after surgery, especially if they're doing their balance exercises and walking and things like that. They can wean themselves off a walker pretty quickly if they need to, or if they have the walker going home. And what was the other one? I'm sorry.
Driving.
Dri-
We talked about driving.
Showering.
Showering.
Yeah.
Yes. So yes, we do want patients to shower. Typically they can shower 2-3 days after surgery. And then we ask them to shower at least every other day, if not every day, and let the water run over their incision to keep it clean and dry, and use a mild shampoo is what we typically ask patients to do.
The important thing with driving is, patients are able to do this without getting really dizzy and feeling unwell. So that's what kind of, and then the other thing I always say is, even if you feel great and you start driving, if you've still got staples in your incision and you get in an accident, it will automatically become your fault, because they'll say you just had brain surgery. Why are you driving? So we usually like them to wait 2 or 3 weeks.
Yeah, I think I was going to say that same thing about being able to move your head back and forth and deal with the dizziness or motion sensitivity you have. And there's driving in rural Minnesota and there's driving in LA. and they're very different beasts. So you have, at some point, patients have to use their own judgment about when are you safe to do various activities.
Mhm.
You know, I've always thought Marina's been working with us a long time now, and I've heard back from her so many times about what patients say or do and are struggling with, and it's been really valuable feedback. I would love to know, you know, across the US, how many people go back to work in 6 weeks? How many people go back in 3 months? When did you feel ready to go back?
Mhm.
What, you know, what was your routine basically post-operatively? And it'd be nice if there was a way to sort of gather that from patients, because we have our sense of what happens, but we don't hear from everybody either. You know,
Right.
there's lots of people go, they went back to work sometime. You know, we see people back at 3 months. It's like, yeah, I'm back at work or what.
That's sort of what we feel too with social media. We do hear from a lot of patients that are able to you know, go back 6 weeks, you know,
Mhm.
and they're okay. But then we hear from others that it's just an ongoing, continuing struggle. And so it would be really interesting to, you know, we have kind of anecdotally what we hear, what we sort of think, but it would be great to really understand that.
I've now commonly kind of warned patients that I think a lot of patients are telling us it takes almost a year to figure out what this new normal is really going to be, where everything's going to settle out, and they're going to say, okay, this is now how I think things are going to be a long term. So I always tell patients, don't be discouraged if you don't think where you are where you were going to be at the 6 week mark or even the 3 month mark, that things continue to change and improve.
Yeah, I think that's a really important point. And a couple of like your balance system is going to continue to evolve. I mean, a lot of progress is made in the first 3 months, but over the next year or two, especially depending on how active you are, it's going to your brain's going to continue to physically change as it adapts. Same for hearing and for tinnitus.
Mhm.
Those things, your brain goes through an adaptation, and there's not much you can do to hurry that along.
Right.
And I think there's this gradual, you know, we all experience this. I think if you have something happen to you, you notice it a lot, and then you notice it less and less, and then you think to yourself, God, I haven't even thought about that pain I had in a
Mhm.
long time. And that's kind of, you know, that's how some of the things will fade away over
Mhm.
long periods of time.
We
One
have a
other
couple.
thing
Go ahead.
sorry, Melissa,
No,
one
you go
other
ahead.
thing I wanted to mention that I just jotted down quickly from a kind of a previous question is, you know, this whole issue of follow-up. And maybe one of the good things that has come out of COVID is now we're doing a lot more video visits with patients. We used to really never be able to do that. There were all these quite strict laws. If you're in North Dakota and I'm in Minnesota and I talk to you as a patient, I'm practicing medicine in North Dakota without a license and those kinds of things. All that's been nicely resolved. So now we can do video visits with patients, you know, at 3 weeks or 6 weeks or something like that, to check on them, to check on the eye care if they have facial weakness. And I got to say, that's been fantastic to, it obviously makes it so easy for patients. They can just be in their home and you know, we can physically see them and talk to them. And so that's been really quite nice.
That's great. We're getting close to the end of our time. I wanted to ask one more question. There were several questions on Facebook about numbness at the incision site, and one, whether or not that would heal or feel better, not heal really, but just feel better or go away. And then another one, there was a patient that whenever they laid flat, that's when the numbness really kicked in, and it was even sometimes described as a headache. So they're using different pillows and things like that. But is there a reason for that why that would sort of be exacerbated by laying flat?
I'm not sure. I'm not sure I know the answer to that, but I can say numbness around or above the incision for either the translab or the retrosigmoid approach is 100%, because when you make an incision in the skin, you cut the cutaneous nerves. And usually it's more noticeable after a retrosigmoid because the incision is a little bit bigger and a little bit more behind the ear. So people will say, oh, I got this numb spot up here. And it almost always goes away. At least that's what patients are telling us. In terms of why the numbness would become unpleasant or more prominent when people are laying flat, I don't think I can answer that. I don't have a good explanation for that.
Okay. All right. Well, we're just about at the end of our hour. So I want to thank all three of you for joining us today, for answering all of our questions. There's several questions still here, and I'm holding on to those. We have an Ask the Doc session at the end of the week. I think it's our very last presentation. So there's a chance we may be able to get to those at that point. We are having a topic on radiation with Dr. Link Friday morning. So I know there's been a couple questions about radiation as well that I just thought I'd hold on to for that presentation. So if you plan to join us again later today, we will be joined by Dr. Bradley, who's going to talk about managing the eye in facial nerve palsy. And then Dr. Price is going to talk to us about facial reanimation surgery. And so the eye presentation will be at 3:45 p.m. Eastern, and the facial reanimation program will be at 5 p.m. Eastern. So thank you all for joining us today. Thank you guys. Thank you, doctors. And thank you, Marina, for answering all these questions. This was really terrific. Thanks so much.
Thanks.
Thank you,
Bye.
Melissa.
Thank you for having us.
Have a good afternoon.